I'm going to be speaking on the treatment of conjunctivochalasis. And to begin with, what is conjunctivochalasis? So chalasis is a Greek term. It refers to relaxing or slackening. And so the term really refers to relaxation of the conjunctiva. It's redundant, loose, non-edematous conjunctiva, usually inferior, usually bulbar, typically increases with age, and it may be associated with hyperopia. So why is this important? Well, we just heard a great lecture about the importance of the tear film, and good quality tear film is important, but it's also important to be able to disperse that tear film throughout the entire ocular surface. As you can see from this patient with very significant conjunctivochalasis, this is going to provide a barrier. It's going to prevent the dispersion of a tear film. It also will disturb the tear meniscus. It may mechanically occlude the punctum, leading to delayed tear clearance or punctal occlusion. Patients most commonly present with tearing. That's the number one complaint. Sometimes burning, irritation. It may last all day. Pain, subconjunctival hemorrhage may be associated and is often associated with dry eyes and foreign body sensation. A good proportion of patients may be asymptomatic, however, with more mild conjunctivochalasis. So why does this happen? May be related to age-related elastoic degeneration. May also be related to the mechanical friction between the eyelid and the ocular surface. You can imagine we blink millions of times in our lifetime, and eventually from that constant blinking, there may be some thinning or stretching of the conjunctiva. Chronic inflammation may play a role, and in patients with more advanced conjunctivochalasis, they've been shown to have increased interleukin levels. And it is also associated with atrophy or loss of Tenon's membranes. So there is a grading system that can be used, going from grade 0 with essentially normal patients without any conjunctival folds to grade 3 with multiple folds and a elevated tear meniscus. In addition to the grading system, punctal occlusion is also assessed, looking for mechanical occlusion with conjunctiva. So in terms of the management, we want to treat any associated conditions, and we often use lubrication, topical steroids, but really the mainstay of treatment for conjunctivochalasis is surgery. This is an example of a patient who came to me after seeing many different eye doctors and years of treatments with drops, ointments, stasis, punctal plugs, and then punctal probing. Doxycycline, et cetera, and still continue to have tearing and burning, and he would be he was a good patient for Conj Cautery, which I performed. So there are several different treatment options, all very similar. Essentially, you just want to get rid of the redundant conjunctiva. Conjunctival excision, which is really the gold standard, using AMT, using sutures or a fibrin sealant, conjunctival fixation, conjunctival cautery, or electrosurgery with a hyfurcator. Now I'll go into a little bit of detail of all these different treatments. So conjunctival excision, as the name implies, essentially a crescent-shaped piece of conjunctiva is removed, typically about 5 millimeters below the inferior limbus, and then the conjunctiva can be closed either with continuous or interrupted silk sutures. So here's some diagrams. The upper diagram, the crescent-shaped excision with primary closure with interrupted silk sutures. Another possibility is to do a conjunctival advancement, advance redundant conjunctiva to the limbus and excise the excess, and then suture the incision. Here's a patient. This is a patient actually of Dr. Hammersmith's who was symptomatic for conjunctivochalasis, had some other ocular issues, as they usually do, but was treated for burning and tearing with many other treatments. Nothing worked, and this patient had a crescent-shaped infranasal excision of conjunctiva with primary closure with improvement. Here's another patient. Unfortunately, it's difficult to really get a great picture of conjunctivochalasis, but this patient did have redundant conjunctiva, was symptomatic, and had excision with primary closure. And this is the patient afterwards. Again, difficult to tell, but the patient did improve symptomatically. Another variation of the same treatment is using AMT. The excess conjunctiva is resected, and then a piece of AMT is used to fill in the gap and adhere to sclera. So Caracal looked at this treatment, 25 eyes with a mean follow-up of a little over 10 months, and he found symptoms resolved completely in 44% of patients with significant improvement in the remaining patients. So it does work well. In this diagram, sutures are used, but glue can certainly be used as well. Another variation, these are all very similar treatments, is the paste, pinch, cut conjunctivoplasty, a neat little term. And essentially what's done is subconjunctival lidocaine can be injected to the inferior conjunctiva to balloon out conjunctiva, and then fibrin glue can be injected through the same opening. The excess conjunctiva can then be pinched and then excised. Okay, you want to pinch for about 20 seconds to allow the glue to seal, and then excision. So Das published on this technique 139 eyes with 3 months follow-up, so not very long follow-up, and over 90% of patients symptomatically improved. One patient did require sutures because of an intraoperative dehiscence. So conjunctival excision is a relatively straightforward procedure, but there are some disadvantages related to sutures. Suture irritation, inflammation, abscess, granuloma, GPC can occur related to sutures. It may lead to a compromised lower fornix, especially if excess conjunctiva is removed. Motility restriction can occur. Fibrin sealants and AMT can also be used, but there are costs associated with those as well as the risk of dehiscence. Another straightforward treatment is conjunctival cautery, and this is a procedure that can be performed in the office, usually 3 to 4 millimeters inferior to the limbus, and redundant conjunctiva. Typically, here's a iPhone video of conjunctiva being grasped with forceps, lifted up, and then cautery applied. Low temp cautery is used, and again, it's a straightforward procedure that can be performed in the office. Nakasato, looked at conjunctival cautery as a treatment for conjunctivochalasis. Looked at 39 eyes with over a year's worth of follow-up, and the symptoms resolved in 36 eyes and improved in the remaining 3 eyes with no recurrence. He did have 6 eyes with scleral adhesion without restrictions. So this is a very straightforward, easy procedure to do. It works well for mild and maybe moderate conjunctivochalasis. For more advanced disease, it may not be that effective. So disadvantages: post-op discomfort, subconjunctival hemorrhage, scarring of Tenon's capsule, especially if cautery is applied directly onto the conjunctiva and sclera without using forceps to lift up. Diplopia and symblepharon can occur, and again, it's more effective for mild disease and not more advanced. Conjunctival fixation is another possibility. The theory here is that the normal fornix is about 8 millimeters in depth, the normal anatomy. And with conjunctivochalasis, often you have a shallowing of the fornix. Conjunctiva is squeezed up, leading to this redundant conjunctiva on the lower eyelid margin. And so the treatment would be to reattach the lower bulbar conj to the sclera, roughly 8 millimeters inferior to the limbus. Taka looked at this procedure. He didn't have that many eyes, 6 eyes, with a good follow-up, and he had no recurrences. The patient did well with symptomatic improvement. And finally, electrosurgery. This is high-frequency radio wave electrosurgery, or the bifurcator, which we're familiar with. And this produces shrinkage without charring tissue. Compared to cautery, there's less post-op discomfort for patients, and this can also be performed in the office as well. So you looked at this procedure with 20 eyes with 3 months of follow-ups. All of his patients improved. 90% went from grade 1 or 2 conjunctivochalasis to grade 0 or no significant conjunctivochalasis. One patient was treated for an undercorrection. Some disadvantages of this are the equipment that's involved, and it may be less effective for conjunctivochalasis. So some surgical pearls. Topical epinephrine can be useful for hemostasis. It's helpful to pinch the conjunctiva to really assess how much excess conjunctiva there is, and that's really to avoid removing too much. You want to avoid removing or cauterizing too much. You can always come back and retreat at a later date. So in summary, consider conjunctivochalasis in the management of patients with ocular surface disease. Conjunctivochalasis often requires surgical management. There are many different options. Most of them are quite straightforward, but we do have many different techniques to choose from. Thank you.